So now we're going to do a case conceptualization using the 8 Ps outlined by the ACA. And again, you can do this different ways. There's a version that has 5 Ps. You can kind of stick to the biopsychosocial plus writing a treatment plan. But this way really goes into a lot of detail of what would go into a case conceptualization. And I thought that this would be a good way to really get an idea of what a very thorough case conceptualization is like. So our client is a 39-year-old Caucasian woman, and she's been referred to therapy after discharging from an inpatient hospitalization for a suicide attempt. Now, she states that she's married, and she says that her husband did come to visit her in the inpatient hospitalization every day that she was there. But when she talks about her marriage, she describes it as happy, but she actually does sound a little bit sad when she talks about it. She does state that her husband is supportive, though. She's very clear that she was discharged at hour 72. That's how she refers to it. And that she's proud that she wasn't held any longer because she saw other people there that were held for sometimes up to 2 weeks at a time, which is the limit for an inpatient hospitalization in this state. When asked why she attempted suicide, she says she doesn't know, but she said that she didn't want to do it. She saw herself taking the pills, and that in her mind she could hear herself screaming, "No, stop, what are you doing?" But that she couldn't actually control her body to stop taking the pills. She said it was as though she was watching herself and had no control over her physical movements. Claire reports that she's experienced suicide ideation nearly every day of her life since she was 10 years old, and she reports an extensive history of childhood abuse, including physical, sexual, and emotional abuse. She also reports that she experienced religious trauma. Client states that her mother died when she was a teenager and that she has been voluntarily out of contact with her father for the last 10 years. She says she does have a younger sibling who she loves very much, but that their relationship is strained, partially due to the trauma that they both experienced in childhood. Client reports symptoms of suicide ideation, dissociation with depersonalization, exposure to trauma, sadness, persistent negative mood, intrusive thoughts, flashbacks, nightmares, persistent negative views of the self, hypervigilance, exaggerated startle response, irritability, rejection sensitivity, excessive worry, rumination, negative self talk, perseveration, sadness, thoughts of death, and disinterest in formerly pleasurable activities, and feelings of hopelessness. So her presenting concern is that she has a history of suicide attempt, depression, and anxiety symptoms, and given her symptomology, it is likely that she has PTSD. Um, I would do an assessment to do a differential diagnosis for PTSD, depression, and anxiety. So predisposition is our second P. This is where the biopsychosocial comes in, and you're also going to start incorporating your theoretical orientation here in order to, at the end of our analysis, get to developing a treatment plan. So for the bio, she does have a family history of mental illness. Client states that her mother was, in her words, deeply mentally ill, but never diagnosed and did not seek any kind of treatment. As for her current biological impact and factors, client says that she does have high blood pressure for which she takes medication, and currently the blood pressure is not controlled by the medication. For the psychological aspect of the biopsychosocial, client demonstrates significant negative core beliefs, including feelings of worthlessness and feeling unloved and unwanted. She says that she feels a sense of detachment from others and struggles to feel connected even within her close relationships. She also states that she feels as though life is pointless and that there's no reason for anybody to be here. She says she doesn't feel like she's a burden and that she does recognize that her death would have caused a lot of pain to the people around her. In social, client states in her childhood she experienced authoritarian parenting from her father and inconsistent parenting from her mother. And she also reports that she experienced parentification from her mother starting at a very young age, approximately 4 or 5 years old. Client states that the sexual abuse was actually from her mother, which is not uncommon, but not always what we expect, and that the physical abuse was from her father. She states that both parents participated in the emotional abuse. Client states that right now she is financially stable because her husband is in a position where he makes a substantial amount of money, but that she grew up in a lower class household and that there was food insecurity in her childhood. And client states that she does not feel connected to any particular culture. Now, this is where you bring in your theoretical orientation. My theoretical orientation is an integration of attachment theory and feminist theory. And I can post another video that gives more details on how you actually develop that integration of two or more theories. But for now, I'm just going to discuss based off of each theory, how I view this through each theory. So, from the attachment perspective, the client says that she experienced significant attachment wounding in childhood. Now, that's also going to come from the abuse from both of her caregivers, but also the parentification is going to create some attachment wounding. Um, so, because she experienced these things, it is likely that she has an insecure attachment style. And given that there's abuse, she does need to be assessed for possibly a disorganized attachment style, because the disorganized attachment style really almost always happens, or almost always is connected to child abuse. Child abuse doesn't mean you'll have disorganized, but disorganized usually means you had child abuse. So, we definitely need to look for that. But she most likely has an insecure attachment style based on how she's describing the feelings of detachment from others. She also reports that she experiences rejection sensitivity in that feeling of disconnectment and a feeling of being frightened by relationships and creating close relationships or having people close to her. She does describe her relationship with her husband as good, but when she describes situations and elements, it sounds codependent. She's saying that they don't go anywhere alone with each other, including going to each other's work situations when they can, and describing struggling to be apart, which suggests codependence. So she has attachment wounding in her childhood and then abuse from her primary caregivers that has likely resulted in PTSD. This client would likely benefit from some of the core elements of attachment theory, which are aligned with common factors, right? So the empathy, the unconditional acceptance, things like that, but also from some reparenting techniques by creating that secure attachment figure inside her and making her her own source of security to allow her to develop a secure attachment style. That will likely eliminate quite a lot of the anxiety and quite a lot of the depression, the feeling of detachment, and some of the feelings of worthlessness that are associated with that. From a feminist perspective, the client reports religious trauma. She states that she was raised in a very patriarchal religion that consumed her daily life, including at school, and that everyone she grew up with was an active participant in this religion. She also reports that although she feels secure in her marriage, she does often feel a sense of insecurity and self-judgment when she fails to live up to traditional gender roles, such as having dinner on the table each night, ironing her husband's clothing, keeping a very clean house, even though she works 50 to 60 hours a week, just like her husband. She also reports that she works in a very sexist work environment and she feels that her career has stalled out in part due to her being a woman and due to her being a woman who is almost 40. So, from the feminist perspective, the patriarchal structure of her childhood and potentially, if there might be a patriarchal structure in her current career, these have left the client feeling very disempowered. And the core of feminist therapy is to create empowerment. The theory is about creating empowerment for self advocacy and social justice. So, the intervention should really be and focused on empowering this client to engage in self advocacy in her marriage and around her career in order to allow her to be in situations that are going to reduce some of the anxiety and shame regarding these areas of this life. So she's very disempowered. We want to create empowerment. So overall, our goals with this integrated theory is that we want to create a secure attachment style that is based on a feeling of empowerment for self advocacy. Now, the precipitants. So these are the things that are perpetuating or causing these symptoms to become worse that happened before. So the childhood trauma is obviously a big one, as is the recent suicide attempt. She states that the suicide attempt has increased her self-loathing, and having been hospitalized has increased her feelings of shame. She doesn't report any physical ailments impacting her. She says that she feels as though she does have friends and a support system, despite that feeling of detachment from others. So, really, in her case, the precipitants are the childhood trauma and the recent suicide attempt. There's only two for her, but these are big. So, we definitely want to be aware. Protective factors are the client reports that she does believe that she is intelligent and that she is capable of change. And she states, if someone tells me what's wrong with me, I know I can fix it. And additional protective factors include her marriage, friendships, and having steady employment. Even though her career is impacting her, the steadiness of the employment is still a protective factor. So she does have some maladaptive patterns. She says that she's a workaholic and that she often uses work to sort of kill time because she's bored and feels that she has nothing else to do in her life. She also reports that she does engage in binge eating episodes approximately 2 times a week, and then she feels an increase in shame afterwards. And she says that she struggles to stop checking her phone, that it's compulsive because of the nature of her work. She constantly feels like she's going to be in trouble if she's not checking her phone. And then when she does check her phone, she tends to get distracted by social media, and then that causes a spiral of shame as well. So, her perpetuants are the cell phone use, the frequent binge eating, and then also her persistent negative view of herself, which includes a belief that she's mentally ill or crazy. So that brings us to our treatment plan. Now, I will create a different video all about treatment plans if that's something that people want. But our main goal, our number one goal in this is going to be we need to create safety and rapport and create a therapeutic alliance, which is always something you want to do with somebody who experienced trauma, particularly attachment trauma or attachment wounding. We want to create that safety by using empathy, unconditional acceptance, by giving the person space to be able to talk and connect with us. We also want her to develop some skills that she can use to recognize traumatic activation and symptoms associated with trauma and be able to bring those symptoms down so that they are not impacting her, so that she can stay in her window of tolerance. So that's going to be one of our treatment goals as well. And then we want to develop a sense of empowerment. We want her to be able to help develop that empowerment and feel that she can self-advocate and stand up for herself and take that part of her that knows that she can change if she knows what's wrong and be able to apply that to the issues in her life that are creating and perpetuating these symptoms. And in this case, I would say her prognosis is good. She does have a support system. She is financially stable. She doesn't have a bunch of life issues that are going to get in the way. And she says that although she's not sure that life has meaning, she is willing to do the work and learn these things because she wants to stop feeling this way. So that is essentially the case conceptualization. You go through all of these elements of a biopsychosocial. You can do the 8 Ps. You can find a shorter one if you want. You identify what's affected her in the past, what's affecting the client now, and then you come up with your treatment plan based off of the needs of the client and your theoretical orientation, which is what resulted in those goals that I just outlined of developing that therapeutic alliance, developing those skills to help her be able to manage her symptoms, and developing empowerment. All of that is related to that attachment feminist lens. And I can show other videos with this client where we can talk about other theories and how those theories would work as well. If that's something you're interested in, just let me know.